Good afternoon, everyone. My name is Jennifer Kovich-Bordenick. I'm the CEO of the eHealth Initiative and Foundation, and I'm delighted to welcome you today to our webinar this afternoon looking at transforming health with social determinants using health coding. This is a really exciting time right now in healthcare, and looking at social determinants of health is a critical area that many different groups are talking about. And we've got really a stellar crew today to talk about this issue and some really proactive things that are taking place right now with payers to help promote this and move it forward. So delighted to have everybody here today. And a really impressive group. We're going to be hearing today from Sheila Shapiro, who's the Senior Vice President of Strategic Community Partnerships at UnitedHealthcare. Nellie Leon Chisholm, who's the Director of Coding and Classification with the American Hospital Association, and Caroline Coates, who's the Vice President of Bold, Goal, and Population Health Strategy at Humana. And I think you're going to be incredibly impressed when you hear about the work that these groups are doing today. Just as some background, we've been meeting with a number of providers and payers over the last several months in a series of roundtables and talking about the importance of this issue. And we have a really, I would say, motivated group of payers who see the importance of this and have really committed to make some significant advancements in this area. So we're delighted to have a group here with us today. As some housekeeping background, if you hadn't noticed, you're muted right now. All participants are muted right now, but we do want to hear from you in the form of your questions. So if you do have a question, you'll see at the bottom of your screen there, there's a little Q&A box. This is not the chat box. Look at the Q&A box. See, it's got a little Q&A next to it. It's to the right of the hand box. So if you want to ask a question, please go ahead and type your question in there. The sooner we get your question, the sooner we can ask your question. So put those in there. If you have a technical difficulty or something not related to the content of the event today, there is a chat box there. So having trouble hearing, those types of things, please go ahead and click on the chat box there and let us know, and we'll get back to you. The questions are already coming in about the slides and recording of this event, which is taking place right now as we speak. So if you would like a copy of the slides or recording, you can check out our resource center at www.eidc.org/resources, and everything is posted up there for your convenience. So please take advantage of that. Next slide. So for those of you who are not familiar with the eHealth Initiative and Foundation, we've been around for 19 years, about to hit our 20th anniversary, and we convene executives from every stakeholder group in healthcare. We're a nonprofit, nonpartisan group made up of really influential corporations and executives across the spectrum of healthcare, focused on identifying what works, where it works, and sharing that information with the rest of the field. We're looking at all of the exciting new technology and innovation happening across healthcare and technology and trying to really pull it all together to help improve care for patients. Next slide. This is just a sampling of some of the groups that we've been doing work with, and I think you're going to hear from a number of different folks today as well, but we really pride ourselves, and we're unique in that we bring all players to the table. This isn't a group of just providers or payers or labs or vendors. We bring everybody under the same tent together, and we look for consensus and trying to really pull all the pieces of the puzzle together. Next slide. Really excited about the work we've been doing in 2019 and which will continue into 2020. We've got 4 great areas of focus that we're looking at. Value-based care, which is looking at cost transparency and prior authorization. We've got a wonderful initiative around there and a number of executives working on projects there. We're doing a lot of work with interoperability, particularly around understanding FHIR and helping people really understand what FHIR means, what it's used for, why it's important, and how to advance that. And then as well, looking at really kind of the workflow issues that all of these interoperability challenges collide with. So that's part of our work as well. And then we have a pretty significant body of work around privacy and security and cybersecurity with medical devices, really trying to advance HIPAA, and looking at consumer protection. How do we get this health liquidity and data to consumers where they are, but at the same time protect their privacy and security? And then finally, which we're going to hear from today, we do a significant amount of work around analytics and social determinants of health, and really trying to understand kind of all these non-traditional sources of data for health and how to make them work better. So that's what we're going to be hearing about today. And just as a reminder, if you're looking for a copy of the slides or a recording, which we're getting more and more questions about, again, I want to encourage you to go to the eHealth Resource Center. There's a whole section up there on social determinants of health. If you have questions, you can look at case studies and papers there. There's a great body of work there for you to take advantage of. And we add hundreds of new case studies and reports there. The other thing you can do is if you have a case study or a report or any work you have done or your organization has done on social determinants of health, please upload it and share it. This is really a great forum for you to share information about what you're doing right now in your personal work, and it's a great venue for you to actually share with others on the phone. We've got a number of folks on the phone today who are really interested in this work, and I encourage you to go and upload your materials there so everybody can see it. All right. And a big thank you to UnitedHealthcare, who's really been at the forefront of a lot of this work. Sheila Shapiro and her group has really made significant strides, and we are a very small nonprofit, and we wouldn't be able to do programs like this without the generosity of groups like UnitedHealthcare really supporting this multi-stakeholder work and work across all different providers and payers have been working on this. So thank you, Sheila, for your support there and UnitedHealthcare. All right, so why don't we go ahead and get started, Sheila? I'm going to turn it over to you and kick off the panel and get us going.
Wonderful. Thank you, Jennifer, and really thank you to the whole EHI team who has worked diligently behind the scenes to actually bring this webinar to all of you. And it looks like we've almost got 560 participants on the phone. So I know that as we go through the webinar today, there'll be questions that you'll be submitting through the Q&A box, and we'll do our best to answer, maybe not your direct question, but Jennifer will be helping us maybe aggregate some of those questions when we get to the end of this session, where we'll be doing that Q&A. If you could go to the next slide, please. We at UnitedHealthcare, and I certainly have had the privilege of working in this space for over 6 years now. I like to say that we were thinking about this topical area and beginning to explore social determinants of health in a very meaningful way before social determinants of health was cool. What I think is fascinating with where we're at as an industry today is how quickly every segment of the healthcare system is really becoming aware of the impacts of those factors outside of the physician's office or the hospital that impact people's overall health. And it is taking really a change in healthcare, and United's goal is to really think about how to change our work from healthcare to overall health. And if you could go to the next slide, please. Thank you. So in 2017, after we had done a few years of trial work around consumer-based interventions with social determinants of health, my team and I became focused on how to build an infrastructure around social determinants of health, because as we looked internal to our organization at various points of touch between our employees and our members, we saw that significant work was already going on to remove barriers to care. we also saw that there was no infrastructure or way to give that data a voice. So as we looked at how to build that infrastructure, we took several things into consideration. One of them was to think about how we not only assisted each person, one person at a time, which is how this work has to be done, but that we needed to understand how to share that information as well. And then trying to look at, if we're removing those barriers, can we actually improve overall health? And you're going to hear from Carlene at Humana about not only the work they're doing, but all of the work that many of you are doing to address these barriers to care is, we all know, making a difference. Our goal overall, obviously, is to improve the overall health of the populations that we serve at United, which is over 50 million individuals across the United States today. If you could go to the next slide. I wanted just to bring some stats forward because in many areas, people think that this is a Medicaid-related issue, or it's isolated to a particular population. And what we're finding is that this is really tied to a socioeconomic shift in our country, not what product someone happens to have from an insurance perspective. And you can see by some of these stats, 40% of Americans can't withstand a $400 emergency. So if you think about high deductible health plans and the shifts in insurance models where employers are picking different options, all of these factors begin to play into those social issues that are creating barriers to care. I'm not going to read all of these to you, but I will point out a couple, and that is in 2018, CMS actually for the first time really expanded their definition of supplemental benefits to include anything related to health for their Medicare Advantage population. That allows payers now to think differently about what those offerings should be in those supplemental benefits, where before we were restricted to things directly tied to health. The other stat that has changed fairly dramatically is the Medicaid information. And as of April, I believe, of this year, now 35 states, this is up from 27 states just a few short months ago, are now requiring managed care plans to do some sort of activity relating to social determinants of health, whether it be collecting data, making referrals, or in some states, as North Carolina is planning to do, actually pay downstream for those social determinant of health services. If you could go to the next slide, please. So where we started to work was to think about scale for every individual in our country, to build a model that allows us to take in very disparate pieces of information and give them a voice, and that voice begins through ICD-10 coding. If you think about when you go to a doctor's office today, one of the first things that they do, besides asking your insurance, is diagnose you. Then you're typically given a referral, whether it's to a specialist or even a referral to a pharmacy to pick up a prescription. That's step 2 in the process. And step 3 is when you actually go to that pharmacy or make that specialty appointment and you follow through. We call that step fulfillment. We built a model that leveraged ICD-10 coding because we found significant evidence of providers using the existing Z codes on their claims. But I will say at United, when we started this work, we weren't doing anything with those codes because they weren't tied directly to a benefit. And now we are. You heard Jennifer talk about the work that EHIDE is doing in bringing organizations together around interoperability. And beside the work that we're doing here in building this model and really advancing this work on behalf of the industry, my colleague, Sagren Moodley, is the chair of the Da Vinci program, which is looking at FHIR standards and interoperability. And one of the our formal collaborations is with the AMA, who is supporting our work around ICD-10 coding and really starting to connect this work that we're talking about today into the interoperability and FHIR standards, so that we're thinking holistically about how to share this information on the front end as all of us begin to expand our thinking into this work. The other organization that many of you may be aware of is Siren. We are assisting with the funding of that project, as well as I sit on the steering committee there, because there are many different touch points and components that have to be thought about as we move down the path of using ICD-10 coding. You can go to the next slide, please. So now that we have a common way to bring data in, one of the other things that we know is that we have to be able to value these services on a national basis. And so we have created a patent pending tool that allows us to provide an estimated market value for every referral that we made. And you'll see on the right-hand side why we believe that this is important. And we are now working to license this tool because we believe it can become the standard by which social services are reviewed on a national basis. If you can go to the next slide, please. Here are some of the statistics that we have at a national level today. And you can see this work is really from 2017 through August of this year. We look to only self-disclosed information. So this is not population attribution. This is a member of United telling someone at any point within their care journey that they need assistance with something related to social determinants of health. Over 1.65 million of them so far. And we've really just begun. We've assisted over 740,000 of those individuals with referrals to social and governmental services, and those referrals equate to almost 1,944,000 separate referrals for those 740,000 people. The imputed market price, or that value to the consumer, is almost $1 billion. And these numbers grow exponentially every month. If you can go to the next slide, please. We believe that this is going to take a different level of collaboration to move the industry forward in a unified way. And one of the things that we are doing at UnitedHealthcare is to make a recommendation to the ICD-10 committee, which we did in March of this year, to expand the Z codes by 23. You can see our partners that we worked with who endorsed this formally, but we had over 300 additional organizations that weighed in support for this particular model. Nellie, who will be speaking with you today, is really one of the instrumental leaders in assisting with the actual implementation of this through her efforts with the American Hospital Association and the ICD-10 cooperating parties, and I'm going to let her speak to this topic. And so I'm going to ask that you go to the final slide. One of the things that brought us here today is that we worked with EHI to convene a group of payers and other interested parties, such as NCQA and the AMA and other organizations, to come together and see if we couldn't all support a unified approach to speaking with our providers and billers to get the word out that ICD-10 coding is available today in its rudimentary form, and really to prepare for the ultimate approval of those additional codes, because we know adoption takes time. What you'll hear today is that my colleagues that have joined me here are doing amazing work in this area. And at the end, I know that you'll hear where you can look for not only the white paper regarding that convening, but also a provider and biller-facing overview document that has been endorsed by over 12 of our major health plan and supporting organizations. And with that, I'd like to turn it over to Nellie, who has really been, as I say, extremely instrumental, and I'm excited to have her here with us today to share.
Thank you, Sheila. Hello, everyone. Next slide, please. A little bit about who we are. The American Hospital Association represents and serves all types of hospitals, healthcare networks, and you can see that we're basically pretty much across the country. And what we do is we help our members reach out in their communities and provide the best care possible. And within the AHA, we have the central office on ICD-10 CM and ICD-10 PCS, which is a collaboration between HHS, the Department of Health and Human Services, specifically through CMS, the Centers for Medicare and Medicaid Services, and the CDC's National Center for Health Statistics. Along with AHIMA and the AHA, we are sometimes referred to as the cooperating parties. And what we do is that we collaborate to develop the official guidelines for coding and reporting that every professional coder in the country uses. And we also provide coding advice through an AHA publication, the Coding Clinic for ICD-10 CM and ICD-10 PCS, and we collaborate in terms of providing guidance where the classification itself may not give you a lot of detail, or we provide interpretation of how the guidelines should be used. And this is a very, very long-standing collaboration going back to 1963 when everyone was using ICD-9 CM. So I have the privilege of representing the AHA in this endeavor. So as Sheila mentioned, I actually have the ability to bring up topics that need clarification through our work together on the editorial advisory board for Coding Clinic. Next slide, please. So the AHA is addressing social determinants of health as part of a larger discussion around value, population health, and health equity. We are committed to providing members with the tools, resources, and education needed to address this issue in our communities. And within that, the Value Initiative is a member-driven effort to support hospitals and health systems as they tackle the issues of advancing affordable health care and promoting value. Addressing population health and the social determinants of health is critical to reducing costs and improving the quality of care provided by hospitals and health systems today and in the future. As a result, AHA has released many resources, including issue briefs, case studies, tools and training, as well as slide decks on these topics as part of the Value Initiative. Next slide, please. So related to our efforts around the Value Initiative, as well as our role in the coding world, we have been providing guidance around coding social determinants of health using the ICD-10 CM Z codes. So what are Z codes, in case you are not that familiar with them? So it's a subset of the ICD-10 CM diagnosis codes that identify factors influencing health status and contact with health services that may be recorded as diagnoses. So they run the gamut of, there might be history codes, status, anything that is a little bit different from an outright medical diagnosis, although there are some history codes that relate to past medical history where there might have been a medical diagnosis in the past. And within these Z codes, there's an even more specialized group of codes in categories Z55 to Z65, which are used to identify persons with potential health hazards related to socioeconomic and psychosocial circumstances, or as they've become better known now, social determinants of health. Some examples of existing ICD-10 CM Z codes for social determinants of health are codes that identify problems related to education, literacy, employment, housing, for example, homelessness, which is the #1 ICD-10 CM Z code for social determinants of health. It's been very useful, and I think people understand the value. But there are also codes related to lack of adequate food or water, or occupational exposure to risk factors like dust, radiation, or toxic agents. So we think that using these codes will allow hospitals and health systems to better track patient needs and identify solutions to improve the health of our communities. And so as part of our work through the AHA Value Initiative, we issued a fact sheet that some of you may have seen. This came out last year. And this was trying to explain the importance of these codes and included the code categories and examples of what's included in each code category. I think it's become a very useful tool in that folks that did not necessarily know that these codes existed could have it all on one pager that at least it would give them where to look. You know, what are the things that go into these buckets that are used in ICD-10 CM. Next slide, please. So generally speaking, coding professionals are bound by the official coding guidelines. And those guidelines stipulate that code assignment is based on the documentation by the patient's provider. And provider is specifically defined in the guidelines as the physician or other qualified healthcare provider legally responsible for establishing the patient's diagnosis. Now, this fact sheet that I mentioned earlier on the previous slide was a way for us to more widely disseminate information that was published in Coding Clinic and eventually became an exception to this guideline. We had discussed with the Coding Clinic Editorial Advisory Board a request from member hospitals around the coding of social determinants of health, where they were thinking that, if the provider as defined within the guidelines was not the person documenting in the record what social determinants of health were affecting the care of that patient, they were thinking that they could not assign these Z codes. So the cooperating parties agreed after discussion that for social determinants of health, code assignment may be based on medical record documentation from clinicians involved in the care of the patient who are not the patient's provider, since the information in categories Z55 to Z65 represents social information rather than medical diagnosis. Now, it's possible that some folks out there were already interpreting it in that way, but this was a way to officially provide the guidance and the permission, so to speak, to use non-provider documentation. And after that, that information was subsequently embedded into the official coding guidelines at the next update, which was effective October 2018. So that was a year ago. Next slide, please. So continuing into this summer, as a result of additional inquiries, as more and more providers and others became interested in using ICD-10 CM codes to capture information on social determinants of health data, we took two more topics for interpretation by the Coding Clinic Editorial Advisory Board, and I'm happy to report that they were quickly agreed upon and published just a few weeks ago in the fourth quarter issue of Coding Clinic. So the first question was related to what is the definition of the term clinician in the guidelines that we had put out last year. And so it's become clear there are individuals in different roles that may be collecting social determinants of health in healthcare settings, for example, social workers or community health workers. So the new guidance clarifies that the guidelines do not have a unique definition of clinicians. I personally looked in different places as far as, what does clinician mean? And so what we decided within the coding world was that in the context of code assignment for the social determinants of health Z codes, and I want to stress, and only for these codes, any documentation that meets regulatory or accreditation standards or internal hospital policies for what gets included in the patient's official medical record, that information could be utilized. In other words, the documentation has to be part of the official medical record, so not some form that gets filled out and then stashed away in a folder somewhere that is used by folks that work on efforts to improve community health and so on. It needs to be part of an individual's official medical record. The second question was whether patient self-reported documentation could be used for coding. And this arose during a discussion during the Siren Gravity Project work group. And Siren is the group that Sheila already mentioned, where the Gravity Project is a national collaborative to improve and harmonize documentation around social determinants of health in EHR systems. So as I was listening to one of the sessions, in the chat box, there was discussion about, can people use patient self-reported documentation? And then also discussions with Sheila. We identified that this was a gap that we don't normally talk about patient self-reported information, but as we discussed in the roundtable that EHI convened, in the end, isn't all information about patient social history patient self-reported. It gets reported to a physician or a nurse or whoever is the intake person, and then it gets documented by somebody else. So in looking at this, we realized that really we needed to address situations where it may just be the patient filling out a checklist, a form. In some of our hospitals, patients are given a tablet to complete this information. And so in discussing this with the coding clinic board, we were able to reach a consensus that if this patient's self-reported information, in other words, this information that gets collected that either patient checks off a form or something in an electronic tool, is actually signed off and incorporated into the health record by either a clinician or provider. So in other words, somebody has to acknowledge it, sign it off, and include it in the patient record, then it would be appropriate to assign codes from Z55 to 65 describing social determinants of health. And with that, I think I've given you a lot of technical issues related to the technical piece of coding, and I'll turn the program over to Caroline.
Thank you, Nellie. Good afternoon, everyone. Caroline Coates here with Humana. Pleasure to be here. Appreciate the collaboration with EHI to really focus on standardizing social determinant of health coding. Given the participation on this call, I think we all recognize it's a very important issue in the evolution of our population health journey in the industry. You can go to the next slide. I just have a few slides I'll touch on and allow some time, as I imagine there are a lot of questions. A little bit about Humana. I think everyone probably knows who we are. Just a couple of highlights in that I think ties in nicely to our focus on this call today is that our North Star is really about achieving best health. And we measure our population health using Healthy Days and have a lot of data underneath that leads us to some pretty impactful social determinants of health that we all see among our populations and need to capture that data to allow all of us to go upstream more in order to really achieve their best health. I draw your attention on this slide to the third bullet down where there's a lot of focus on really delivering the right care in the right place for the patients and our members, and we all probably share that. Again, I think historically with just the focus on clinical health, that's been challenging to do. So to really look at our members and population's health holistically with a focus on capturing data around their social health allows us to really leverage that. With Humana's 5 specific points of influence around this, we are really going deep in pharmacy, primary care, behavioral health, home health, and social determinants of health. And specifically to that, you can go to the next slide. About 5 years ago, we launched what we call our bold goal, which is what I lead, which is really ambitious goal to improve the health of the communities we serve 20% by 2020 and beyond. And it's definitely beyond. We'll be taking this well into our future. And this is really about going deep and understanding what are the barriers in our communities to our members achieving their best health, and it's again led us down this path of really going deep in social determinants of health, and not just screening, but providing the tools and capabilities to our providers to capture that information, right? Which is much of what you've heard today, but it's fragmented today. And while we have a lot of providers billing these Z codes, there's not a lot of consistency. So I think to Sheila's point, this is really about collaboration now and all of us coming together to align on the right codes to foster streamline and ease of workflow in the provider's office so we can holistically capture this data and go more upstream around our communities and populations. The next slide, which I think is my last slide, is really a little bit of a journey. So I think a main takeaway around where we see the population health strategy and our bold goal being a catalyst is transitioning us from an insurance company with elements of health to a health company with elements of insurance. And that's really around helping to transform our industry to thinking and working differently and building the capabilities and resources so our providers or any consumer-facing individual, pharmacist, case manager in a home, right, is equipped with the right tools and resources to capture data on all of our members' health. I think, Sheila, you pointed out the data just around how much of our overall health is representative of our social health more than clinical. So this journey is really about that, where we establish bold goal in 2015. We have a lot of deep dive efforts specific to loneliness and social isolation, food insecurity, that has allowed us to develop some predictive models and in the spirit of capturing as much data as we can. And that is really allowing us to get deeper into building that data ecosystem around our members. And I would just draw your attention to the end of this timeline around the social risk adjustment score, which I think plays really well into our overall goal here to get some standardized coding. I think the coding is data, and our clinicians are often trained to diagnose and treat. The data allows them to diagnose, and the resources that we are all providing through our communities allows them to treat. But if we can align and standardize around the right codes to capture the total and holistic health of our members, that will allow us to go even more upstream in anticipating what is the social risk environment of that member and of that population to ultimately affect how we deliver healthcare overall. We have some ambitious goals around all of this, and I often say the bold goal is our mission. It's evolved into a broader population health strategy, and I often say that this is not just about Humana or one payer or one partner or one provider. This is about all of us really coming together, and again, applaud the efforts of this roundtable to kind of break those walls down and discuss what are the right codes so we can capture what's going on around our members, so we can continue to deliver the right care in the right place at the right time, and together improve the health of the communities that we all serve. So I went through those fast, but I know we have a wide audience with likely a lot of questions, so I will stop there. Appreciate the opportunity.
That was great, and actually we're getting a lot of virtual nods from folks and comments in the chat box saying, I hear that every day. This sounds like I'm experiencing the field. So it seems like our presentations are spot on here. So Caroline and maybe Sheila, you could comment on, people are looking for kind of some examples of the types of social services that could be provided based on, an identified SDOH need. Could you give a few examples?
Of course.
Caroline, yeah. Would you like to go? And then I'll tag in.
Yeah, that's fine. Yeah, so I mentioned the focus on social isolation and loneliness, for example. So I touch on that one because I think it's a harder nut to crack a little bit than food insecurity, because you can't give a pill or a prescription for it. So depending on the needs of that individual, so there's not one solution that fits all, but perhaps a referral to a community group, a fitness organization, and a guidance center. We, like many other plans, are partnering with some companies that contract with individuals to make social visits in people's homes and have that interaction, knowing that all these social determinants of health are multifactorial. If there is something like food included, right, there are meal delivery services, but also include that social aspect or that friendly visit. So just a couple initial reactions specific to those two particular social determinants of health.
And I'll just add on that there was a question I saw around the codes that were requested, and certainly we will provide that through the EHI site. It is also public information on the ICD-10 code site under the CMS website. But an example of where we saw a gap, you heard it is with transportation as an example. Transportation, at least from the work we've done so far, is one of the top 3 issues that people are dealing with. And there are various ways to solve that, anywhere from looking at a benefit and making sure that individuals know how to utilize that if they have one, all the way to those social and or alternative methods that everyone is starting to look to. But without a code, it was very difficult to try and solution. So that is an example of one. I would say we are able to capture that information within the United systems, and that allowed us to provide not only the recommendation to the ICD-10 committee, but using data to support our ask, and not just the ask in and of itself. And those are some examples of, at a higher level, of how we're seeking to fill those gaps so that we all have a standardized way to look at what I call this newly known information.
Yeah, great.
Yeah, and this is,
sorry,
this is Caroline. I just saw a question. I thought it was a really good one come up, and basically saying this is all great, but from a workflow perspective, it's challenging and it's hard, right? And I think that touches on something we're all seeing in the network evolutionary with some organized networks or infrastructures, if you will, that are kind of sewing together our community-based organizations. There are numerous companies out there doing this in various markets. And so I would just answer your question generally that, well, one, I agree. Two, I think it's really important that what I'll call the social networks, so kind of technological platforms that are creating the infrastructure of these social networks to be supported to allow kind of that one referral, if you will, right? So you're never going to find, in my opinion, a person who has just one social determinant of health. So through data, if we can help flag the more higher social risk individuals to that provider, being the diagnostic information, and then help refer them to kind of a holistic network of resources, I think that will help in the workflow process.
Great. And Nellie, I want to get you in here because we've got a number of questions about, and I don't know if you have any data on this, in terms of the number of providers who are using ICD-10 codes or, using Z codes actually in claims and coding and ways to incentivize them. Do you have any thoughts on that?
Yeah, and I want to sort of stress that I'm talking about the Z codes specifically to social determinants because I think that providers do use Z codes in general in other categories for other things. And, it's a little bit confusing in that we do know that there is a significant increase in interest in addressing social determinants of health. We know that providers have all kinds of programs to address these things, but we don't see that represented in the claims data, and that's kind of where we're getting involved in trying to incentivize, explain why there's a need to put it into the claims. Because when we look at claims data, only about 10% of claims submitted across all payers today include a Z code for social determinants, although we do hear that there's more activity going on. So for the hospitals that are utilizing them, they're doing that in a couple of ways. They are documenting social determinant information in their EMRs. Then they use this information to identify the needs of individual patients. They may be screening their patients and referring them to the care team, but it's not showing up translated into a Z code related to these factors that ends up in the claim. So I think the information is there. It just hasn't been collected in a meaningful way that is available to others to look in the aggregate. They're using it to work with individual patients, individual community members, but not in the aggregate so that people can identify programs that could be created, or even, as we've heard from Sheila and Caroline, that a case could be made for additional resources or payments to identify ways to help these individuals.
Great point. We've had a number of comments, and Sheila, this came out a lot in our discussions about kind of the follow-up or closing the loop to make sure services are received, or what happens if services are not received. Can you speak to that a little bit?
Sure. I saw a question about what was what happened to the delta between those individuals that we've identified and those where we've made referrals. And I will say some of the identification has not yet been acted on, just because we get identification sooner than we're able to make referrals. And I would say that as we look at the referral process, when it's coming, and these numbers are all tied directly to work that United is doing. So this is not what providers or hospitals may be doing to assist the member, like you heard Nellie say, because until we start to share that with each other, we don't know who's doing what. these numbers were coming directly from what we're doing within United, and that means most of it is trying to get with folks via telephone. And so we all know that that's difficult to recontact a person. So now we're building in different processes to try and get further upstream, as Caroline said, to assist at point of identification, if at all possible. This third step of fulfillment, I'm sure Caroline has thoughts on this as well. Fulfillment is very difficult because in the healthcare system today, as you heard folks speak about, diagnosing is one step, but the treatment in this regard is via a social or governmental service, and they don't track who the health plan is. They don't track information in many social agencies, even down at the member demographic level. They're there to assist, and their dollars come through grants and federal funding. And as all of us do, you report based on the individual requirements from the organization providing you the dollars. So fulfillment is something that we've just started to work on directly with community health workers, with provider organizations now who are already doing this. I think we can take a page from the federally qualified health centers who have been doing social referrals as part of their charter for years. They have figured out how to build it into their workflows. And I think that as we all start to share best practices around this new horizon that we're entering into, there are ways that we can learn from each other, and that would be one of the places that we've looked to see how to do better fulfillment data capture.
Yeah, and Sheila, to your point, I mean, that requires trust and relationships with the community-based organizations, right? And this doesn't happen overnight. So the bold goal that I mentioned that Humana set 5 years ago, a large part of this work the last 4 or 5 years in our bold goal communities has been dedicated to building the trust and relationship with those organizations so we can live, eat, and breathe and know what are the right resources, where are they located, how can we connect those to the right referring person, and it's population health, right? It takes time, and there are some, I think savvy digital and technological solutions that are popping up in our industry to help give them more of the infrastructure and capabilities that they frankly need so they can scale and increase capacity and be able to accept these referrals as they will undoubtedly increase.
And I just want to, follow up on that, because we have a number of questions about kind of this trust issue, and a number of folks are asking about, if we have reservations about collecting and sending screening results. And this came up a lot in our discussions as well, the whole idea of kind of consenting for this. So Sheila, Caroline, could you guys speak to that issue?
I would say the way that we treat this data is all HIPAA protected. So it is self-disclosed information. It's not attribution data that we're trying to act on. And at this point, as Caroline mentioned, we're not directly making a referral to a social agency on behalf of a member. We are assisting that member to the level that that individual wants help. So if they're, may not have a computer or don't know how to get online to fill out a SNAP enrollment form, and they want help from us, we're helping them do that. In certain instances, people would prefer to do that on their own, but they need to know where and who to contact. And so that information would be given at that level. That these issues I think are the kinds of issues that we'll all grapple with as we seek to make the process more streamlined. And I think, as Caroline mentioned, some of these aggregators that are beginning to emerge are not only serving in an aggregation model, but they're also serving as what I would call, in very loose definitions, a clearinghouse. Not only a clearinghouse of data, but a clearinghouse of validation of security practices and ability to exchange data in a way that healthcare has come to take for granted.
Yeah, I agree, Sheila. So I concur with your comment that we include all of it under the HIPAA umbrella. And then when it comes to referrals from clinicians to these sources via these aggregators, there is an additional individual member-issued privacy consent form and process. So that's something new. And to your point, Sheila, I think this will be continued evolution as we as an industry get our arms around whole person health.
And can you guys speak to how other stakeholders are getting involved, like community groups, pharmaceutical groups? How can these other groups get involved in this effort?
Yeah, that's a big question. So in our local markets, we have a designated, what we call healthcare advisory board that's made up of the community. It's made up of constituents of all these organizations that come together regularly and align on what to address and build that consensus and what to focus on. So healthcare is local. I would say that you don't underestimate the power of the local communities and that alignment and consensus and coming together around that. I know enough to be dangerous, can speak to some of the pharmaceutical industries, but I've been impressed to see some pop up with, for example, just leaders now in population health that are talking about, for example, incorporating social determinants of health into things like clinical trials. We weren't hearing that even a couple years ago. And so, I think, Sheila, you said at the beginning, we were saying social determinants of health before it was cool. And it's growing fast and trending, and to see just commitment to this space from more non-traditional entities, I think, is an example of that movement. So everyone's coming to the table every day in a faster way to create that alignment, recognizing, we really do also work together.
And, I know in the spirit of time and being sensitive to everybody's time, I just wanted to thank everyone not that has joined the call, but also all of you who are working in this space. It is the next generation of health, and it, as was mentioned, it's not easy work to change a system, and it takes all of us pulling in the same direction to really take these topics one at a time. Because it's a multifaceted solution that has to occur. And I hope you've heard today, from coding to the work that Nellie has done, to the data collection and great work that Humana is doing. We all are taking a part of this very complex new health system and beginning to operationalize it. And we look forward to hearing from all of you in your individual work. And I'll turn it back to Jennifer.
And unfortunately, we didn't have time to get up to all the questions today. I think we're going to have to do another Q&A session to get through a number of these. There's clearly a lot of interest in this. And I do want to thank our speakers today for joining us and everybody on the phone. There are a ton of materials online there. I know there are a lot of specific questions we've been getting in about the Z codes, and we will try to provide some more information there where we can, and continue to create materials to help explain this as well. So thank you to our speakers, and thank you for joining us today. I think it's been a tremendous afternoon. Appreciate everybody's time. Have a wonderful day.
Thank you.
Thanks.
Thank you.
Thank you.